Bismillahirrahmanirrahim. I am Professor Mirza Sharif, and today we are going to do the clinical examination of the chest. Now, before starting the clinical examination of the chest, we need to remember few of the landmarks and the surface marking of the lung, pleura, heart, and the others. Today we are now before starting the clinical examination of the chest, we need to remember few of the landmarks. Over the chest, lungs, they go 2.5 centimeter above the upper end of the clavicle like this, and then you draw a line over the costochondral junctions up to the sixth rib, and in the mid clavicular line, this is the attachment of the pleura and as well as the reflection of the lung. So the lungs and the pleura both are at the level of the sixth rib in the mid-clavicular line. In the mid-axillary line, the pleura is at the level of the 10th rib, while the lungs are at the level of the 8th rib. And in the posterior axillary line, pleura is attached to the 12th rib and the lungs they go up to the 10th rib. So this is the surface marking of the pleura and the lungs. Then there are two fissures. One is the greater fissure and the other one is the horizontal fissure. Greater fissure starts posteriorly at the spine of the second thoracic vertebra. It comes down obliquely anteriorly and it joins the lower margin and anterior end of the sixth rib. While the horizontal fissure, you draw a horizontal line at the lower margin of the fourth rib anterior end, and this marks the middle lobe between the two fissures, and below it is the lower lobe and above is the upper lobe. On the left side, there is only one greater fissure, there is no horizontal fissure. So the right lung has got three lobes while the left lung has got two lobes. These both the lungs they are divided into bronchopulmonary segments. There are 10 bronchopulmonary segments on both sides, and it's very easy to remember the 10 bronchopulmonary segments, and the simple formula is A palm and A malp. A for apical, P for posterior, A for anterior, L for lateral, M for medial. These are the bronchopulmonary segments of the upper lobe, and then the for the lower and the middle lobe is the A malp, A M A L P. So these are the 10 bronchopulmonary segments. Medial and lateral basal segments on the right side, they are replaced by the superior and inferior lingular segments on the left side. And on the left, you have the heart, the area of the precordium that should always be kept in mind. The examination of the chest starts with the adequate exposure of the chest, which should be at least up to the mid abdomen, and the person should be lying supine in the bed. To start the inspection, first of all, you go to the foot end of the patient and you see the patient from the foot end of the patient, and your head should be or eyes should be at the level of the patient. You compare the right side with the left side, and if there is any bulge or any area which is depressed, that should be picked up. Along with that, if there are prominent veins, any scar, that also be picked up. And then the important thing is the movements of the chest. If the both sides of the chest they are moving equally with the respiration or not. Then is any pulsation visible as far as the apex fluid is concerned? That should also be noted. After you have seen all these things, then you concentrate on the chest and its relation with the respiration. The supraclavicular, suprasternal, and the infraclavicular fossae should be seen carefully during the inspiration. If there is an inward movement or indrawing of the, then that's a sign of the airway obstruction. The recession of the intercostal spaces should be observed during the inspiration. After observing the supraclavicular, suprasternal, infraclavicular foci and the intercostal spaces during the inspiration, note down the movement of the abdomen with the respiration. Normally, the abdomen moves out during inspiration and it goes in during the expiration. But if somebody is having the severe airway obstruction, then what will happen is that the abdomen will move out during inspiration and during the expirations, the flanks they will go in. This is because of the use of the accessory muscles during the expiration. And if it's present, it's a sign of the severe airway obstruction. Along with that, you need to note the movement of the Adam's apple, whether the trachea is sucked in into the thoracic cavity during inspiration or not. So these are the things which you need to see in the inspection. After the inspection, we start the palpation. And in the palpation, first of all, we look for any area of tenderness over the chest with gentle palpation. And at the same time, we can also pick up the presence of the subcutaneous emphysema in these patients. Then, if there is no tenderness and no subcutaneous emphysema, then we look for the apex beat. We place our hand over the precordium and we try to localize the apex bead, and then we place your finger over the apex bead and then count the spaces and see in which line is the apex bead. Is it its normal place or is it displaced? Because its displacement will give you the idea about the displacement of the inferior mediastinum. Then how do you take the mid-clavicular line? You extend your fingers like this, place the thumb over the clavicle, medial end of the clavicle, and the middle finger over the distal end of the or outer end of the clavicle, and flex your index finger. This will come to the middle of the two. From here, you draw a vertical line, and this is the mid-clavicular line. After you have localized the apex beat, then you go to the trachea. And over the trachea, you have to look for two things. One is the position of the trachea, and second is if there is any tracheal tug or not. The patient head should be straight, slightly extended, and use three fingers. And this is how you use your three fingers. Your middle finger should stay in the center of these two lateral fingers, the index and the ring finger. You place these two lateral fingers over the sternoclavicular joint. You press your middle finger into the suprasternal notch and move it up and down. So you place it like this, push into the suprasternal notch and move it up and down like this. And you feel the trachea rings with the middle finger. If you feel the trachea rings over the central part of your middle finger, then the trachea is central. But if you feel them to the either side, then trachea is displaced to that side. Then to look for the tracheal tug, there are two methods. One is that you place your three fingers above the suprasternal notch and you ask the patient to take a deep breath and see whether the Adam's apple moves downwards and the distance decreases to two fingers or not. If the distance decreases to two fingers, then the tracheal tug is positive. Second is that you push your finger between the trachea and the sternum and you ask the patient to take a deep breath. If your finger is caught tightly between the trachea and the sternum, then the tracheal tug is present. After the apex beat and the trachea, you come down to the chest movements. The chest movements are checked in three parts: the upper third, middle third, and the lower third. For the upper third, you place your two hands like this over the upper third of the chest. Bring your eyes to the level of your hands and you ask the patient to take a deep breath. गहरी सांस लें. And you note the movement of the hands if they are equal or not. If one side is moving less compared to the other, that side will be considered abnormal, and all the findings on that side will be considered abnormal, which may be increased or decreased. Then, for the middle third, to feel the movements in the middle and the lower part, you slightly abduct your fingers like this and you place them over the side of the chest, retract the skin, and bring your thumbs in the center of the chest, and you ask the patient to take a deep breath. Gary सांस लें. And you see if both the sides they move equally from the midline. The side which moves less again will be abnormal. Similarly, in the lower part of the chest, retract the skin, bring your thumbs to the center, and ask the patient to take a deep breath. गहरी सांस लें. Okay. So this was to check the movements. Onwards, we'll examine the lateral part of the chest along with the chest front part. Beyond this examination, the lateral part of the chest is also included for examination from the front. Because the movements on the lateral part they are not checked, they are checked on the anteriorly and posteriorly. In the palpation, the next is the vocal fragmentus. The vocal fragmentus is checked with the ulnar side of your hand. You place it over the chest and you come downwards in the mid-clavicular line on the right side, while you on the left side, when you come to the second intercostal space, you slightly move it outwards so that you leave the area of the precordium. So you ask the patient to say 99, 99,
99.
and compare it with the other side. Come down, check it, compare it with the other side. And the voice should not be very loud. If the voice is low, then the difference will be more easily appreciated. After you have done the vocal fragmentness over the anterior part, you check it on the lateral part as well. And you start from the axilla. And to check the vocal fragmentness in the axilla, you make a fist, you push it into the axilla, and you ask the patient to say 99.
99.
Compare it with the other side, you can use your other hand to do it like this. And then you come down and you check the lateral part and compare it with the other side of the chest. So this was for the vocal fragmentus. For the percussion of the chest, the first thing is that you should know how to perform the percussion and how to keep your hands and use your right hand for this percussion. Your left hand or the fingers should be extended and they should be in firm opposition of the chest wall. For your right hand, you flex your little finger, you flex your ring finger, you extend your index finger, extend your thumb and make them stiff so that they can't be moved. So when you make them stiff, your middle finger comes down automatically to the 90 degrees and then you can use it like a hammer to strike the other finger. So this is the method how to give the shape for striking of your right hand and how to place the left hand over the chest wall. And then you percuss over the middle part of the middle phalanx and after striking take off your finger, don't keep it over the fingers, otherwise the sounds will be damped. So you percuss like this, compare it with the other side. Now mind it, the percussion of the whole of the chest is the light percussion. The percussion of the whole of the chest is light percussion except the percussion of the dome of the diaphragm or the upper border of the liver. And why it is so, that is also going to be demonstrated to you, and I think you will appreciate it. When you come down, Over here, the note has changed, and this is in the fifth intercostal space or just above the sixth rib. Now, what happens when we do the heavy percussion? This is the heavy percussion. So the note has changed. For light percussion, the note changed over here, and with the heavy percussion, it changed one space above compared to this one. This is the difference, or this is the line up to which the lungs they come down, and this is where the dome of the diaphragm is because it is rounded and it goes up. So for the percussion of the upper border of the liver, the percussion should be heavy percussion. After the anterior part of the chest, you also percuss the lateral sides of the chest or the lateral wall of the chest, and for that you place your finger, push it into the axilla, and then you strike it. Compare it with the other side and come down. So this is how you should do the percussion in the chest. After the percussion, we go to the auscultation. In the auscultation, we do the two things. One is the vocal resonance, in which we ask the patient to say 99, and instead of placing our hand, we place the stethoscope and we listen the sound with the stethoscope and compare it with the other sides. And then we interpret it by using the chest movement as a parameter, because the side which moves less will be considered abnormal, and all the findings on that side will be considered abnormal. After the vocal parameters, we auscultate the chest for the breath sounds. That during the quiet environment at night, you place your stat over the chest, listen to your chest with the full inspiration and expiration, and concentrate on the first of all the air entry, whether it is equal on both sides, which simply means if the breath sounds are of the same intensity on both sides, then you can say that the air entry is equal on both sides. Then you concentrate on the inspiration, length of the inspiration, and the length of the expiration. In a normal person, the inspiration is longer than expiration. There is no pause between the inspiration and expiration, and it will be rustling in character. In the vesicular breathing, the inspiration is longer than expiration. There is no pause between the two. It is rustling in character. While in the bronchi, if you want to listen the bronchial breath, you place the stethoscope over the trachea and then you concentrate on the sounds. The inspiration will be shorter, expiration will be longer, there will be a pause between the two, and it will be tubular or blowing in character. This is called the bronchial breath. In patients with the airway obstruction, you come across a breathing in which the expiration is prolonged, there is no pause between the two, and it is harsh in character. So, how do you describe it? You will say that the patient has got a harsh vesicular breathing with prolonged expiration. In the auscultation of the chest, we check the vocal resonance and we check the breath sounds over both parts of the chest. In vocal resonance, we use the stethoscope instead of hands and ask the patient to say 99 and compare the right and the left side and the lateral parts of the chest. The rhonchi are the whistling sounds which you hear in the expiration if the disease is not very severe, but when it becomes severe, they can be audible both in the inspiration as well as in expiration. Then the crepitations. These can be early inspiratory, mid inspiratory, late inspiratory, or pan inspiratory. Early and mid are due to the fibrosis of the lung or the secretion present in the bronchoalveolar tree. To differentiate between the two, we ask the patient to cough. If they change their character with the coughing, they will be called the infective crepitations, which is because of the dislodgement of the secretions from its original place during coughing. If they do not change their character, they are considered to be due to the fibrosis of the lung. The late inspiratory crepitations are usually fine, and they are due to the opening of the alveoli during the end of the they are due to the opening of the alveoli at the end of the inspiration, and these are heard in patients with the heart failure. Pan-inspiratory crepitations, they are like the sound of a velcro when you try to pull it apart. This type of sound, or the coarse or the loud crepitations, you hear in patients with the interstitial lung disease. Then another sound which you can hear is the pleural rub. Now this pleural rub, in when present in the body anywhere, in the lungs, in the heart, over the liver, over the spleen, or the other parts of the body like over the tendons, scratch your ear lobule with your nail like this and listen to the sound. This is called the leathery sound, and you, wherever you hear it, this will be called a rub. Over the lungs, it will be pleural rub. And the few other characters of this rub are that when you press the stethoscope over the chest, it becomes louder. Then it comes both on the corresponding phases of the inspiration as well as expiration, and then it will be leathery in character. Then another sound which you can hear over the precordium, that is the mediastinal crunch. These are the crackling sound which come with each heartbeat, and these are due to the mediastinal emphysema. After the examination of the front and the side of the chest, we go to the back of the patient, and we we do all the four things: the inspection, palpation, percussion, and auscultation on the back of the patient. And the patient is preferably in the sitting posture. The two things which we left while we were examining the front and the side of the chest was to comment about the shape of the chest. The shape of the chest cannot be commented until unless you see the patient in the lateral profile and you compare the anterior, anteroposterior and the transverse diameters. To compare you have to take the transverse diameter of the patient like this. You place your two hands over the sides and you measure this distance between the two hands. This is the transverse diameter of the chest. For the anteroposterior diameter, you place one hand over the front and other on the one on the front and other on the back of the patient, and you measure this distance between the. If the anteroposterior diameter is less than two-thirds of the transverse diameter of the chest, then the chest is elliptical. Another thing which was left, that is the total chest expansion. You take a measuring tape and put it around the chest at the level of the nipple, and you ask the patient to take a deep breath. Then you come to the inspection of the chest. Again, all the things which you noted on the front, they are the same on the back side. Then comes the palpation. In the palpation of the chest, first you should check the movements of the chest in the upper third of the chest, then middle and the lower third of the chest. For the upper third, you place your two hands like this, bring your thumbs in the center, and you ask the patient to take a deep breath. गहरी सांस लें मुंह से. हाँ. Ask the patient to take a deep breath, and you see the upward movement of your thumbs. If it is equal on both sides, then the chest movements in the upper third, they are equal. For the middle and the lower third, the method is the same as we did on the front of the chest. Retract the skin, bring your thumbs in the center, and ask the patient to take a deep breath. गहरी सांस लें. Similarly, the lower third. After the chest movements, you go to the vocal parameters, and for the vocal parameters, we do it in on the apices, and then we come down. So you do it for vocal parameters is done on 3 points: 1, 2, 3, 1, 2, and 3. Then compare the two, and after that you ask the patient to cross the hands like this, and the scapulae, when they move out, the area of examination becomes more clear. So you start from above downwards, ask the patient to say 99, and compare the right with the left side. After the vocal parameters, you go to the percussion, and again for the percussion, the same points: 1, 2, 3. Compare it with the other side, and then you come down like this. Compare it with the other side like this. Then comes the vocal resonance and the auscultation of the rest of the chest. In the vocal resonance, we again use the stethoscope instead of the other side of your palm, and you ask the patient to say 99 and in a low voice, and then compare the two sides, and the side on which the movements were decreased will be considered abnormal. After the vocal resonance, you auscultate the chest as we did on the front and the sides of the chest. Look for the type of the breathing, whether it is vesicular, harsh vesicular, or tubular, or bronchial, and then if there is any added sound present in the chest or not, like the rhonchi, the crepitations, or the pleural rub. So, with the picking up of all these findings, we come to the end of the examination of the chest. And with this, I thank you all for your attention. Allah Hafiz.